Hi everyone, I'm Anu Kathiresan, fertility physician and Dr. Mom, and here to educate on fertility. There are different types of frozen embryo transfer protocols. So in this video, we will talk about a specific protocol called the Medicated Frozen Embryo Transfer Protocol. So let's start that discussion now. Prior to planning a medicated frozen embryo transfer cycle, it's first important to make sure the goals for that patient were met with the IVF cycle in terms of the sex of the embryos, in terms of the number of embryos to hopefully achieve their family building goals. So assuming that that has taken place, then the next thing is also to make sure the uterine cavity has already been evaluated. And that can be done either with a saline ultrasound, a FemView, or a hysteroscopy. We just want to make sure the uterus looks nice and normal before we put the embryo back in. The other thing that we'd ideally like to do is what's called a mock transfer or a trial transfer. And this is just a practice run at putting the embryo back in. We just don't want to run into any surprise on the real day of the transfer. So assuming all these things are done, then we can move forward with our plans for the frozen embryo transfer. For a medicated frozen embryo transfer cycle, the premise is that we are giving the medications, the estrogen and progesterone, to simulate what would happen in a menstrual cycle, but the ovaries actually remain quiet. They are not growing a follicle, they are not ovulating, so we're giving all the medication to simulate what that process would look like at the level of the uterus. Women that don't have regular cycles or have ovulation dysfunction are generally a good candidate for this type of protocol. And the advantage of this type of protocol is that there is more flexibility in terms of the duration of the medication. So for example, if a woman has a thin lining, we have the ability to extend the time of estrogen that woman could take, and also the amount of estrogen that woman could take to hopefully thicken the lining to get it to the place that we need it to be. In addition, if we need to schedule the transfer on a specific date, there's more flexibility with that, with this type of protocol compared to the other protocols. Pregnancy rates are similar between all the protocols, so there's no right or wrong in terms of that perspective. So it's good to discuss with your physician all the protocol options and discuss with them which protocol would be best for you. Having said that, now let's go over the steps of a medicated frozen embryo transfer protocol. The steps of a medicated frozen embryo transfer protocol can be broken down into about 4 steps. So the first step is when we start estrogen. So the process will begin with the patient calling with their period, and then we'll bring them in around cycle day 2 to 4 approximately, and we'll bring them in and do ultrasound and blood work. And we want to make sure everything looks good to start, particularly that the estrogen and progesterone are low, and then we'll begin. And then we give estrogen. Estrogen can be in different forms and dosages, so it could be oral pills, it could be vaginal pills, it can be a patch in patients who have had previous history of thin linings. Sometimes it can even be IM injections. And then we'll continue the estrogen for approximately 1 to 2 weeks and bring the patient in for a lining check. What we're looking for is a certain thickness of the lining that can vary clinic to clinic, but it's approximately 7 millimeters is the thickness that we're looking for. And we're also looking for a certain characteristic of the lining called a trilaminar appearance, where you see this particular 3-line appearance. Assuming that these thresholds are met, then we will start the progesterone. If the patient does not have the right thickness, then sometimes we'll extend the estrogen for an additional week, maybe add estrogen in a different form and bring them back in another week and reassess the lining. This leads me to the next step, which is progesterone. So we start the progesterone once the appropriate thickness of the lining is reached and it has a trilaminar appearance. Once we start the progesterone, we plan for the transfer on the 6th day of progesterone. The progesterone can be in different forms. It can be in IM shots, it can be in vaginal suppositories, or a combination of both. This leads me to the embryo transfer. The embryo transfer is usually performed on the 6th day of progesterone if the embryo was frozen at the blastocyst stage. The embryo will be thawed that morning, and there's approximately a 95% survival rate for the embryo to survive the thaw. The next concern is how many embryos do we put back in. Nowadays, we do a lot of genetic testing, and so this has dramatically increased our success rates that we usually will recommend putting one embryo back in at a time. But every patient's clinical history is different, so please discuss this with your healthcare provider. The next thing is how we actually do the procedure. I have done a video on the embryo transfer, and I will link it here, and also preparation for the embryo transfer. But to briefly summarize, you'll come in that day with a full bladder. Some clinics don't use any anesthesia, some use oral Valium, either is really okay. And we will put a speculum in, perform a gentle lavage, and then advance a soft catheter into the cervix and in the uterus, and then deposit the embryo near the top of the uterus, and then we'll gently remove the catheter. Patients will then rest for about 20 to 30 minutes before they'll get up and leave the clinic that day. The last step is checking the pregnancy test. We typically will check the pregnancy test anywhere from 9 to 14 days after the embryo transfer. If the pregnancy test is positive, then we'll repeat it about 48 hours later, and we're looking for an appropriate rise in the beta-HCG level. If we see that appropriate rise, then we'll schedule the first OB ultrasound at approximately 6 weeks of gestation, which is about 2 weeks from when we check that initial beta-HCG. Another thing to keep in mind is that if everything is progressing properly, we will also continue the estrogen and progesterone. And the duration of that continuation can vary clinic to clinic, but because that patient did not grow a follicle, did not ovulate, there's no corpus luteum there making progesterone. So we need to continue this medication until the placenta takes over hormone production, which is approximately 7 to 9 weeks. So clinics will usually continue the estrogen progesterone. Again, it can vary, but something along the lines of 8 to 10 weeks of gestation. So ultimately, it's approximately 2 months of estrogen and progesterone. So that's something to keep in mind. If the beta-HCG rise is not appropriate, then we're concerned if the pregnancy might be a miscarriage or might be an ectopic pregnancy. So we'll keep a closer eye on that patient in that circumstance and bring them in for ultrasound and blood work. The last scenario is if the beta-HCG is negative. If that were the case, then we'll have patients stop their medication, and then they'll meet with their physician to discuss their next steps from there. That is it for this video. Please remember that every patient is different, so please discuss your own clinical history with your provider to determine which protocol might be best for you. I hope you found this video helpful. If you did, I hope you'll give the video a like. Don't forget to subscribe down below. If you have comments or questions, you can leave them for me there also. Thank you again so much for watching, and see you in the next video.